Good evening, everyone. Welcome to day 2 of the virtual Future of Health Summit. My name is Fifi Peters. I am happy to be back with you all again as we discuss how to transform a critical sector in our economy, being health. The dream is for every South African to have access to quality and affordable based healthcare, but the reality is the complete opposite. Structural ailments like the lack of medical insurance, dilapidated facilities, and a significant shortage of doctors and nurses are holding the system back, and in turn holding the economy back. But there is hope. And that hope lies in Africa's most valuable resource, its youth. With their vibrant spirit and determination, young people can be the driving force of transforming the healthcare sector and making it fit for purpose. Their willingness also to embrace change, particularly innovation brought by technology, brings immense opportunity to create a world in which access to quality healthcare is no longer a luxury, but a norm. If you were with us yesterday, you will know that we discussed topics including the role that technology can play in overhauling the healthcare system. We also looked at how to improve existing healthcare infrastructure. South Africa's Health Minister, Dr. Zweli Mkhize, also shared an encouraging message about government's plan to chart the sector forward using innovation, increasing investments in infrastructure and skills development. Today, we will take the focus on skills development a little bit further, unpacking where the gaps are and what needs to be done to fill the holes. We'll also speak to the key issues of burnout and how to create the ideal work environment that will retain the talent that is needed to strengthen our healthcare system. We do look forward to hearing your comments on the matter, and you can share them with us and any questions that you have throughout the webinar using the webinar platform and also on social media using the hashtag FOH Summit and hashtag Future Health. Let's begin. Our first discussion for this evening will be looking at the current gaps in healthcare education and training and how to address them. According to the Future of Health Index, the biggest skill gaps amongst young healthcare professionals is in the non-clinical skills like business administration and management of hospitals and also clinics. Now, while some practices seem to be providing continuous education to close the gap, a significant amount of clinics are not. Here are the panelists that will take the discussion further.
Saul Cornick, co-founder and CEO of HealthForce. Professor Andrew K.L. Robinson, Deputy Dean for Strategy and Business Development at the Faculty of Health Sciences at Northwest University. Beatrice Mutale, UNFPA Representative for South Africa and Country Director for Eswatini and Botswana Country Offices. Joel Oborogo, Founder and CEO of Sen Health.
Good evening and a warm welcome to you all.
Thank you.
Good evening.
Good evening. I do have Joel with me in studio, and if you were tuned in yesterday, you will know that Joel was on the panel and we couldn't quite get to him, but he's given us his gracious time of being with us in studio today. And I suppose let me begin the question to him. Joel, in terms of the healthcare or the gaps in healthcare education and training, from your experience working in the space in South Africa, in Africa, where do you currently see those gaps? And perhaps a question on, what are the trends emerging? Have you seen in the years that you have been in the space the gaps widening, or have they been narrowing as perhaps governments and the private sector have been making inroads to try and close them?
Okay. Thank you, Fifi. Thanks for having me in here. Recently in July, just during this pandemic situation, we ran a survey. And our survey was really focused on healthcare professionals in Africa and those in the diaspora. Mm-hmm. And the sort of feedback we got and the insights were quite interesting. The first key thing that we found out was that there's a willingness to understand more, especially with technology. How can these healthcare professionals leverage technology appropriately to deliver in their jobs? And then there's collaboration between those who are based in on the continent and those in the diaspora, because there's a lot of migration of health workers. So you have health workers living in various African countries. For instance, in South Africa, South Africans working in the UK and US who have skills over there, develop new skills and findings, come back here and actually are able to leverage the best form of technology that will work on the continent. So what we found is that with that, there's a lot of gap in that. There's a lot of things we can do, but technology is a key finder and a key game changer. And we can use technology in various ways in the business administration area, in healthcare, when you're talking about patient registration and stuff. You can use it in clinical workflow, and there's quite a lot we can do in that, which I think I will unpack as we go along. But definitely there's a very strong willingness for healthcare professionals to understand technology from that space and how it can be used to automate part of their work that's repetitive and also augment where you have clinical decision making, which is quite important.
Right, right.
Yes.
To bring the rest of the panel in, so Sol is saying that there's a willingness to use technology and embrace it a lot more. And I suppose that in all of our industries, with the new innovations that are coming, there needs to be that willingness because we're constantly learning on the go. But according to the Future of Health Index, an area that is concerning right now in our health space, particularly South Africa's health space, is the low level of competency, if I can put it that way, without insulting any of the healthcare professionals, but the low level of competency in non-clinical skills, not related to their expertise and specialities in health. So business administration and managing efficiencies within the hospitals. I'd like to get the panel's view on this, and also where you are seeing perhaps other gaps in healthcare education. And Sol, if you can just kick that off for us.
Yeah, sure. I mean, I'd just like to reiterate what Joel was saying, that definitely the use of technology is something that is going to be key to the way healthcare workers deliver healthcare. It may not be as readily available in the public sector as it is in the private sector. I think as NHI starts rolling out and government starts contracting with the private sector to deliver services in a cost-effective way, and to allow health workers to reach places they may not be physically situated, digital health is going to play an important role. We've, just to give some context for where I'm coming from, Health Force has set up a system that allows nurses to run their clinics effectively and to call doctors in through a remote telemedicine connection. So of course there's a desire, we're seeing a strong desire from doctors to participate in this, to be part of this remote practice, serving clinics all around the country, serving people wealthy and not wealthy. But I'd actually like to add one other non-clinical skill that I'm seeing a massive gap in, and that's the understanding of the health system. We're finding a lot of doctors in particular who are trained as clinicians to deal with each individual case excellently, yet they ultimately land up in leadership positions without an understanding of how the different pieces of the healthcare system come together to allow the efficient use of that system. And actually, much more than that, to re-engineer the way healthcare is delivered such that they can utilize a multidisciplinary team in the most cost-effective and actually in the way that delivers the best health outcomes. And they're lacking that health system understanding as much as it's the business acumen and the management and everything else. I think I'm seeing that as quite a big gap. And again, I'm seeing it because we're bringing doctors into our practice and we're asking them to lead teams of nurses in delivering multidisciplinary care to patients. And that's actually ending up being quite a new experience for them.
Yeah. So can I stay with you a moment longer, perhaps for you to provide an example of what do you mean when you say some of the health care professionals that you're working with are not understanding the healthcare system? What about the healthcare system is not clicking the way it should be?
Let me give you an example of a classic example of where a health system understanding would really benefit the way teams of health workers can work together. Let's just take diabetes or hypertension. I think it's now one of the biggest killers, two of the biggest killers in South Africa in terms of non-communicable diseases. These diseases aren't treated by a doctor, neither are they treated by a nurse, neither are they treated by an endocrinologist or any other specialist. It requires a team to understand the disease and to manage the system, whether it's an out-of-hospital piece or an in-hospital referral, whether it's supporting patients that are coming back out of hospital, whether it's understanding the funding mechanisms to be able to provide care, whether it's understanding what each health worker needs to do at each stage of that disease. This is a basic example of how a health system should function in treating a disease with lots of different disciplines contributing. And we're finding that as a result of the history of South Africa as a fee-for-service model, in particular in the private sector, where doctors are paid for the services they deliver, as a result, doctors are doing things nurses should be doing. Right. Or GPs are doing things when they should be referring on to specialists, because that's how they're earning a living. And so we're seeing doctors focusing on the patient at hand, and we're not seeing them having that systemic view, that single view of the patient, and understanding how that patient should move through the health system. It's not their fault. I don't think it's part of their training, and I don't think it's part of the incentives of the system to push them to understand how they should be caring for the patient rather than just trying to make a living and make ends meet.
All right. Then it's not their fault, you say. You have identified that perhaps there is a shortcoming in overall training of understanding the overall system. And just speaking to the health index here, which does find that of the young professionals surveyed in South Africa, 45% of them felt that their education did not adequately prepare them for that level of understanding, perhaps speaking specifically to business administration tasks. And Andrew, just to bring you in here then, as you do speak to the gap, focusing on the non-clinical skills and, not to finger point anyone in the process, but how we change the ratio so that more and more young professionals come into the system with a better understanding of the entire system.
You're on mute, Andrew.
Thank you, Fifi. Thank you for the opportunity. I studied it. I specialized in public health, and I also did a diploma in health services management. So that gives me a very in-depth understanding. And what Saul says is that medical professionals, when they come out of health professional schools, are have very little knowledge of systems and of their role as advocates for patients to ensure that patients within possibly faulty systems are supported. And it's not necessary that this debate as who should be the administrators of health is a debate which the pendulum swings. From one side, it's got to be doctors and health professionals managing, and on the other side, you need competent administrators to do it. So I still feel that the best administrator in the health arena is a health professional with a management or a business training to augment, because a non-health professional in a health professional administrative post will have to call in a health professional if there's a specific problem, because it's not only an administrative problem, but it's usually to do with the patient, and they haven't got the ability to put the two together. So that cadre of health professionals that have this understanding of health services management and systems is important. But you don't need, not every medic needs it, but they do need to be inducted into it. I mean, executive office is a small part of the whole system. And doctors are trained largely for their clinical skills, their hand skills, etc. So, but there also isn't recognition for, and I can give you a perfect example. There isn't recognition for doctors with administrative skills to be placed in senior administration as a medic. My example, I was placed in a senior executive position in the province, and I was only paid according to that executive position. I got no remuneration for my public health specialty degree, and that value that I brought to the post hasn't been recognized. Some provinces in South Africa have started doing it and are recognizing the value of a health professional with an additional management business qualification, and recognizing both and not just one or the other. So there needs to be that recognition. And
Yeah, so the monetary incentive, I think,
public health.
if I can just jump in there, I mean, I think monetary incentive, particularly in these times, is something that I think quite a lot of workers across all industries are pushing hard for. But I do understand the frustration of investing so much in oneself and taking on more responsibility and not being recognized for it. Before I wrap up, particularly on the business administration side and the management side of it, in terms of a skills gap, I just want to get the opening remarks from Beatrice. Beatrice, I mean, Andrew's saying that not every healthcare professional necessarily needs to have these skills. I mean, it is a small component in operating and running hospitals, in his view. What is your view, and you know, whether young professionals do need to be diversifying their medical skills and just adding perhaps even the basics of non-clinical skills as they do go forward in this new normal?
Thank you, Fifi, and really appreciate all the partners that came together to organize this webinar, because I think it's really critical that we discuss the gaps in the system, the clinical and non-clinical gaps within the system. I come from UNFPA, and our focus really is on working towards universal access to sexual and reproductive health, as well as population and data. So I'd like to actually pick on some of the points that were raised yesterday, and I do agree with the two previous panelists that it is important that we do have health professionals who have the other skills, who get trained and have their capacity built in the management and administrative skills, because ultimately they end up managing the facilities, and for them to do it effectively, they need some skills building in that area. But I would like to touch more on the data part of it, because data is also another non-clinical skill that I think is very critical to the healthcare system. With data, what we find in the system, and this is not just South Africa. South Africa is one of those countries comparatively in sub-Saharan Africa that has a fairly advanced data management system across, when compared to other African countries. But that said, there are still gaps in data, and gaps in data have a ripple effect and actually contribute to really minimizing the potential that the health system as a whole could have. Because without data, without a harmonized system of collecting, analyzing, and utilizing data, we get a situation where you find that health facilities or the whole healthcare system is in a situation where you find that you probably you don't even have a picture of the human resources as a whole. And when I talk of human resources, you may not have a complete picture of the size, the composition, and where they are deployed. It also affects the whole supply chain management system. It also causes a disconnect between the efforts to increase the number of medical professionals, young people being trained, and the ability of the public health system to integrate them into the system, and to integrate them in places and areas where they're needed most. And then it also sometimes leads to the maldistribution of the healthcare professionals across the system. And all that goes to really affect the efficacy of the system. So I think the whole area of data management is an area where we need to think about within the health system. And we need to find a way where existing health professionals get that training, or at least we have healthcare professionals within the system who are able to support the system, provide this aggregated data on an ongoing basis, so that the providers are able to make informed decisions in a timely manner.
All right. And Beatrice, thanks so much for ushering us into the next gap. And let's address the data gap, because according to the index, it does find it as an area of concern, and it finds that almost half of the young people that were surveyed this time around found that they were overwhelmed by the amount of data that they had to, amount of patient data, of course, that they had to terse through. Joel, what the research also paints is a picture in which sometimes access to sufficient and complete data is also a challenge, which then again makes, creates a further gap. And I'm just interested in your view on the data gap, your experience on how much of a problem it is, particularly as there's also a view that, access to, these restrictions that are put in place for young people to grapple on some of this data that will make them or will enable them to make important health decisions. What's your view there?
Well, the way I see it, in our experience, what we found with the data challenge is multiple fold of challenges there. So yesterday when the minister spoke, he talked about a digital first approach being a very important aspect of moving things forward. We strongly advocate that that's the way to go. And also, Saul mentioned a minute ago, or a few minutes ago, he talked about the health ecosystem.
Right.
Now, within the health ecosystem, the way data has to move across the health ecosystem, and each of the players in the health ecosystem understanding the relevance of the health data in such a way that we can create, because the whole idea is to create data lakes being structured and unstructured data, such that we can now really mine this data and use these technologies. So going back to the digital first approach, it's quite important that we look at mobile apps, systems in which we can use to capture data digitally. And then the next thing is on training these young individuals. Most of them are they're digital natives. They're very good and very used to most of the mobile applications and systems and smart devices. They're accessible. So what we have to do is, in my view, is two things. And one of the things we are doing at Sen Health is that we have a course which we launched recently, which looks into technology in healthcare, looking across all areas of technology, including blockchain, artificial intelligence, and health devices, IoT. Why are we doing this? It's important that people understand the building blocks of these digital technologies so that they understand the sensitivity of that data, applying GDPR, POPI Act and everything, but more importantly, understanding the key metrics that business will need, health, public sector will need, and the metrics the doctors need when we're talking about sensitive health data. And then another thing we can leverage is patient-generated health data. Now, patient-generated health data, we have to look at health literacy for the patients and the health consumer. Because if we're looking at a digital-first approach, to complete that whole circle, we need a situation where I, as a health consumer, as a patient, I'm already digitizing and connecting to you. So you find out that you find a lot of companies in South Africa already doing that. You have a blockchain kind of startup in South Africa. We have a Recommend which does appointments. So all these things are already being digitized. And the next thing is, how do we scale training, both online and offline? And how do we really connect the dots such that people can really get to understand how to really manage and use digital products. So I think moving things forward is a digital first approach.
A digital first, we have to.
Yes, we do.
If there's anything that COVID-19 has taught us, certainly we have to, because the findings do suggest that young professionals do believe that a blended approach of training and support staff and guidelines will certainly help them to use digital patient data a lot more effectively. I'd like to get the rest of the panel's thoughts on recommendations to address the data gap in your view, Sol?
Yeah, I mean, I agree with the different levels of data that Joel's talking about. I just want to bring a patient focus to it. I think there are two layers that we look at data from in terms of caring for the patient. The one is at the individual patient level. And at that level, you want the health worker, and certainly when you're talking about health promotion, you want the individual patient as well, the individual to have their data. But at a health system level, you want a single view, a single data view of that patient, irrespective of where the patient goes in the health system. Without that single view, it's impossible for health workers across the system to treat all the problems the patient needs solved at any given time. And so that single digital view becomes absolutely critical of the patient as they move across. And a big problem with that is the interoperability between systems, particularly in the private sector, where there's a huge amount of fragmentation. But certainly in government as well, where data is shared across different platforms is very difficult. The second level that one needs to consider data at in order to be able to deliver really good care to people is at a population health level. Because particular regions will have particular issues. Resourcing can be planned based on the data as it describes a particular group of people, as it describes a particular region. Planning outcomes based on programs implemented can be measured. Better programs or better outcomes can be scaled up and others can be brought back. So again, the population health level is a really important level at which to collect data and make it available for decision making. A single view of the patient, and then the population health level. That would be what I'd contribute to the thinking around the need around in data transformation.
And just before we wrap up the discussion on the specific topic of data transformation or addressing the data gap, Andrew, some final thoughts from you on this matter?
Yeah, I agree with what has been said. There needs to be direct data entry and that technology to enable it, because at the moment data is being manually entered and it is extremely labor intensive and it's extremely poor quality. Most of the provinces non-financial data on these things which Saul was talking about, the population base and the usage, etc. Most of the provinces have disclaimers or have audit findings, and the amount of data that is expected to be collected is incredible. I'll give you the picture so you can understand the poor data quality of entry. And then if you're sitting flying a jumbo jet, you've got all your dials, and they tend to zero at they'll zero at a certain point, and you'll know how to fly the plane. But the data quality is of such a standard that you aren't sure whether what you have received is real or not, and so you're really flying the plane by looking out of the window and getting other impact information onto the data. The talk of technology and health is very important. However, technology is not a healthcare system. You can go to any hospital this minute, any clinic this minute, and you'll see evidence of health technology lying around in various states of disrepair. The ability to maintain the technology, firstly, and secondly, there's been an explosion, a technological explosion that you spoke about, and the engineers developing this technology are just interested in the solution and not necessarily in the implementation of these. And many very good solutions just won't be practical to implement because the systems aren't in a position to receive it. But I agree, data is important. Enough data is important, and the artificial intelligence processes which will start data mining is going to help us. And what Saul's talking about mentioned was interoperability. That's crucial. And in terms of the patient-centeredness, I would argue that the patient is the person that should carry their data on their device. Most people have devices, a minority doesn't, and I wouldn't. And interoperability from those mobile devices to other devices is important, and I'm sure there's systems that can ensure that.
Assuming that everyone has a smart phone, of course. But I must say, in terms of the data conversation from a patient perspective, it is nice if in the event that a particular GP that you're used to seeing is not available, being able to assign away the privilege of the GP at hand to see a medical track record of your history and not having to go through the tedious process of explaining some of your previous ailments to to enable further treatment. So the access to data and greater data and being able to read it, obviously it does. I see how it improves efficiencies in the clinics. It certainly improves efficiencies for patients like me, who sometimes don't have a lot of time even to treat themselves. But nonetheless, let's move on to another gap that has been identified as being crucial, and that is the knowledge gap. And it's the knowledge gap particularly pertaining to value-based care. And Beatrice, I'd like your view on value-based care and why we should be knowing more about this, and also, you know, whether this is where healthcare should go. This is how we should be measuring outcomes based on value rather than on volume, as is currently the case.
Thank you, Vicky, for that question. I hope I understand it correctly. But I wouldn't say one against the other. I think in terms of measuring the healthcare system, I think the healthcare is important, but the quality of services that an individual gets, I think, is very important, and how a patient is treated, how they perceive they are received, I think is all very important, because it then also impacts the reaction of the patient as to whether they would come back for a repeat service, or whether they would not come back, or whether they would feel they are getting the services from the healthcare system or not. I mean, for myself, particularly working with young people, we've noted that as you work with young people, particularly as we try to get young people needing sexual and reproductive health services, and you refer them to health facilities, regular health facilities, many of them end up not going to those facilities, or they'll go once and they will not go again. And in the end, they get all kinds of challenges with regard to their reproductive health. We know the range of them, the infections they get, or the unwanted pregnancies, etc. But what we have found from, over the years is that when young people are attended to by a youth-friendly provider, somebody who's really really thinks like young people, who they feel they see themselves in that provider, then you find that they do end up going, and the results you get increase. You get more young people going. They go back for their services, and they also refer other young people. And then you also you get into the situation where you avoid young people getting into situations of unwanted pregnancies, getting into situations of infections with HIV, STIs, etc., because they are getting the right services from the providers that they feel are treating them appropriately. So I would say it is both, but I would say the value-based approach is also very equally important.
All right, so it's not one against the other, and I'd like to get the panel's views on this in just a moment, because we do have some comments that are coming through from the audience. In fact, the first one from Dr. Shinara, who of course was a panelist yesterday speaking to addressing the healthcare infrastructure challenge. And she does say that we are presented with quite an interesting dilemma in the fact that you've got the requirements for most vacancies being that for clinicians or nurses, including managerial posts, whereas a public health specialist would also be an excellent candidate with systems training. And this is something that perhaps government needs to be aware of. If I'm understanding that correctly, Joel, so you've got a situation in which you have vacancies for more healthcare professionals, but you also have these healthcare professionals that can fill these roles will also be excellent in providing the training for others who perhaps don't have non-clinical skills. And perhaps and we had a private hospital group, the RH Bupela, that was listed, that is listed on the JSC yesterday, speaking to the fact that yes, it is true that a lot of young professionals are lacking in the non-clinical skills elements, but there's not enough people within the hospitals to pass over that training. So it is that dilemma, and I don't know if you have a view on addressing that dilemma.
Yeah, yes, sorry, excuse me. Yes, I do. I think the key thing is balance, because when you look at this, most of the people who can actually transfer these skill sets, their workload is very busy. Look at the typical day of a nurse or a doctor. They're quite busy. And so we have to really start exploring other ways in which this training and skills transfer can be done. So I feel personally that there's not enough use of certain technology tools to use on that training. That's one. The other aspect we have to look at when it comes to skills transfer and training is that we have to realize that when we're looking at a digital first approach and we're going into a digital world, you have to start looking at the new roles of the health worker, hybrid roles that will come out. So you find out that quite a number of people within the system who are clinicians, as you mentioned, can start to pivot into digital scribes, where we're actually understanding how to scale using technology, using AI, and also training other people. So these are the best set of people to come together, including data scientists and people like ourselves who develop these soft systems, and work as a multifunctional team to develop solutions that will stick. Because if you develop in isolation either way, you don't really get that adoption of those sort of things. So in my view, I hear what they're saying, and it makes sense. I think that there has to be a willingness to be more open-minded about the job roles and looking at how do you really allow people to pivot. Because in most cases, most people pigeonhole people based on perception or what they have to do. And so it's a matter of giving the opportunity to the individual. So I feel it's more a mindset and a cultural kind of thing. You have to impact the work culture more than a technology sort of thing. So I feel that that problem is addressable in looking at things on a bigger scale. Digital first, the work culture, and also looking at how can people pivot and really move to the future of work, because it's going to change.
Okay, certainly. Your thoughts then, value-based care versus volume-based care? I mean, is it one or the other, or like Beatrice, should we be embracing both?
Beatrice is correct in embracing both. I feel that it's going to be more on value-based care. I lean more to value-based care. The reason being that there's a very strong paradigm shift to patient-centric care. If you look at it, in the last few years, we had organizational-centric focus, where each organization within the health ecosystem are developing solutions and working in how they interact with patients or each other based on the organization. Now the patient is at the center of everything. So with a patient-centric care, we actually have to change how we look at this. And for the patient, it's very critical, the health outcomes. And the health outcomes impacts and leads to value-based care. So that's the direction we're leading. And then the other paradigm shift we have to be aware about is that I know most people are a bit hesitant about technology, because I do work with a number of GP practices and we do look at developing such solutions. Hence, we introduce the course, which I'm talking about. But what is important here is that technology is shifting to understand people. You're seeing that AI is becoming more human-like, predictive. And as it gets stronger and moves towards that direction, inevitably we'll actually end up in there. So I think the gaps between both is closing. I feel where we need to really be focusing our work on is opening up on how do we see the future and how do we see each of the players and within the healthcare sector interacting and working with each other so that we can get more efficient in using technology.
All right, we'll pick up that thoughts in just a moment, but just to the rest of the panelists regarding the topic of value-based care. So we've got quite a mixed view so far coming from Beatrice and from Joel. So your view, because what was interesting is that quite a number of young professionals who were surveyed operating in South Africa's healthcare system didn't even know what value-based healthcare meant. Showing that, of course, that is an area that needs working on, or does it?
Yeah, I'm not sure how many people listening to this webinar even understand it either. If I define, maybe can I start by defining what I understand to be value-based care? And the best summary I'd give it is that you are measuring the outcomes of the work you do, working to improve outcomes at lower cost. That's what value essentially is. Better health outcomes at lower cost. And healthcare is one of these strange anomalies. It's very different to any other normal good in the world. There's no other normal good in the world like healthcare. The difference is that when you spend more at a systemic level on healthcare, often the less you get. And value-based healthcare looks to really capitalize on that by understanding what the outcomes are that are delivered at the lowest possible cost. I'll give you an example of why often spending more can result in worse value. If I have a shoulder injury, actually, no, let's take a more common example. A pregnant woman in South Africa's private sector will go to her gynecologist for antenatal care. Mm-hmm. And 80% of those women will land up with a cesarean section. As opposed to the public sector in South Africa or any other health system around the world, which is nurse-led, which is primary care-led, where the cesarean section rate is only 20%. Mm-hmm. Now, the 60% of women who get a cesarean section have complications as a result of that surgery that make it worse for them and their babies. Certainly, there's a group of women who need a cesarean section. But here, spending more on a specialist for antenatal care and for childbirth when it's not really necessary, not only results in higher costs, but it results in worse health outcomes. So my view is that it should be very much about value-based care. The idealist in me says it's all about value-based care. How can we improve the health outcomes for patients with the limited amount of resources available? The realist in me says that as a result of the previous two topics we've discussed, it's going to be very, very hard right now. First of all, because you need data to understand health outcomes. You need data to understand population health, individual health, and the outcomes of particular programs. And we don't have that right now. And the second reason is because the only way you can deliver value is by having a health system approach to delivering healthcare, where the appropriate health worker delivers the appropriate care at the appropriate time based on the need of the patient at that time, which really requires that health system overview. And without those two things, the delivery of value-based healthcare is very difficult, but it's not impossible. We're on track for it.
So, I do find this conversation quite interesting, and particularly as it pertains to cost, because yes, the patient should be at the center of this model, and it should be about access to the best quality care that is most affordable. But of course, we also have private sector players that are accountable to their shareholders, and a lower cost for the patient sometimes doesn't necessarily translate into an efficient way of operations for these companies that are accountable to shareholders. I don't know, just thoughts are there. If Andrew, if we just could get your views on this debate, value-based versus volume-based, and perhaps maybe given the business perspective, how it affects them and the likely uptake of value-based healthcare as we do move forward, or paint a picture of the future of healthcare in South Africa today.
Right. The value-based is pivotal, and entities that take this as a central, as an important aspect, and they measure outcomes that matter to patients. So they're not interested in how many hip replacements or tonsillectomies that are done. They're interested in that person who had the hip replacement. How was that outcome for that patient? And in working with that, and in working with the value, they often find that the operational costs are reduced, because in looking at value, their value looks at the whole system, and improvements are made, and outcomes are improved. So it's pivotal. The issue of shareholder interests, the King 4 people, King 4. Guidelines, etc., are looking very hard at the profit motive driving healthcare and the commoditization of healthcare. And I can give an example of the public sector doing cardiothoracic surgery at nearly 60 to 70% less cost and similar out to the private sector in South Africa. So the cost of healthcare is is not coming down. And if we want to look at the major gap, if we look where we are at the moment with COVID and the state of health in the world is sick, South Africa is sick, and do you think our health systems are geared to push us into a healthier place after COVID? No. And the gaps in the health system is providing curative care. It's a curative system largely. You're bringing people, and we've spoken of hospitals, clinics, treatment. You can get as many hospitals and as many clinics and as many health professionals as you like. But if you don't look at the upstream causes of that ill health, we'll still be in the same position. So one of the biggest gaps is promoting health and rather than treating disease. And the budget allocation, there's a huge disparity in it because obviously clinical care is expensive, but even with the health promotion budgets being trimmed, it doesn't make sense.
Right.
So I think we need to really look at what professional are we training, what type of healthcare professional. Are we looking for a curative hospice-centric care, which we've got, and what most of the speaking has been about, the data and the health technology to do stuff, or the environment that creates a healthy environment that enables health to be the norm? Because at the moment, more than 60%, and in Africa, non-communicable diseases has eclipsed communicable diseases. And in Africa, to hear that is quite a bitter pill to swallow. So we've got to really shift the paradigm.
Thanks. You know, Andrew, I have to jump in there. We are unfortunately running out of time, and you have given us quite a lot to think about, and perhaps this is something that you as the audience members can provide your comments and thoughts to in the next panel that we will be having shortly. But Beatrice, just as we wrap up and we get into some closing remarks, there's a question that has come regarding, data, the subject that you raised, and the fact that it is the new currency on all fronts. And, while ownership of this data, Beatrice, the question goes, while ownership of this data should be in the hands of the patient, it isn't. And patients are becoming aware of the importance of their data and their health record. And this can bring about potential legal ramifications. That question coming from Susan Thomas, and thank you for that. Beatrice, what are your thoughts on that?
Yes, the whole question of data is, I think the question really brings to point the fact that as we talk about data and the importance of data, it's very important or critical that we ensure that there is security with regard to that data. Because as rightfully said by the person who raised the question, if that data gets out into the public, it could raise serious consequences for the healthcare system or for the hospital, the provider. So the data security is an aspect that really has to be taken into consideration going forward. But I'd also like to add that when we talk about data, yes, the data belongs to the patient, but there's also that part of the data that is very critical for the policymakers, the decision makers, because they need to get that data, that compiled and analyzed data, for them to respond to the gaps in the healthcare system and know exactly where the gaps are and how they need to respond to them. So yes, data belongs to the individual, but there is the compiled data that belongs to the system. And if the system is to work effectively, we need that data to reach the policymakers, whether it's at the national level, at the provincial level, or at the local level, if they are to respond to the community effectively.
All right. Beatrice, thanks so much for handling that. And we have unfortunately come to the end of that particular discussion, and I know that there's a lot more that needed to be said. Perhaps the panel can filter in some of the comments in the next panel that is coming up, because it is kind of related in terms of, well, I'll introduce you to the next panel in just a moment, but before I do, I just want to thank you all, and thank you all for your insights and really giving us food for thought and in thinking about how we can certainly address the the gap, the data gap, the education gap, and the training gap when it comes to the future of health. So on screen, you do have Saul Cornick, the co-founder and CEO of HealthForce, who is joining the conversation, Professor Andrew Robinson, Deputy Dean for Strategy and Business Development at the Faculty of Health Sciences in the Northwest University, Beatrice Mutali, the United Nations Population Fund representative for South Africa and country director for the Eswatini and Botswana country offices, and of course in studio, Joel Ogborogo, who is the founder and CEO of Sen Health. Thank you to you all.